So coming back to Dr. McNamara first. So if somebody showed up on Monday to your clinic because on the routine ultrasound that we normally do, they found a spot in the liver, what would you do? What are you going to do? How do you start? And kind of, how do you normally guide your patients into the next steps?
Sure. So, you know, I mean, I think the first thing that we do is we usually look at the imaging, and sometimes we'll call the radiologist, but it's always a tough visit, I think, because there's a lot of angst, I think, that we all have when you come in and you get a scan done and you don't know what it shows, and I'm the first person that you see. I try to appreciate that first. So we sit down, we talk about the findings, and then, you know, the next thing I do is I say, look, there's something there. We need to figure out if it's something that's real, something that we need to be worried about, or if it's nothing at all. And sometimes it's nothing. So the next thing I do is try to get a biopsy of the liver. So we look at where this spot is, we talk to the radiologist, and we say, can you put a needle in this spot and obtain a piece of tissue? After that, we sit down and we get scans of the rest of the body. And we really try to estimate where in the body this cancer is, if that's what's happened. Is it only in the liver? Is it in the liver and the lungs? Is it in the liver and someplace else? If it's in the liver, then how much is there? And we start using our judgment to figure out what the next step is, what the next therapy is. Is it surgery and RFA? Is it something else? But we always start with the biopsy, and some people kind of question that. They say, what else could it be? But many times it's other things. We found colon cancers, we found other types of cancers. We find that if we repeat the imaging or look at it a different way, it's something that's not cancer at all. So the ultrasounds are good, they're easy, they're fast, but they're not an answer. So the next thing we have to do, if they come in with an ultrasound that shows something, is get a better look. Try to get an answer.
Okay. Well, so once you confirmed with the biopsy, moved now to Dr. Shoushtari, you say you have a biopsy-proven liver metastasis, right, and there is also something in the lung, for example. So for a patient like that, what would you do?
So I think it's useful in a room full of patients to acknowledge, just as everyone else has done, that what it actually means for you when you get that news. And obviously it's devastating. It's anxiety-provoking. It throws off all your plans for life and everything else. I think the first instinct for everybody is to sort of say, how can I fix this problem? You know, and if somebody, the first person you meet usually has the biggest power to direct you, because that's when you're at your most vulnerable, or that's the person that you go to and you're still in shock, you know, phase one of the sort of acceptance. So the first thing that we do is actually, I mean, we're a little bit different because we're in Manhattan, so unless you live, you know, there, usually you're sent there by somebody else. And I think that's a very important lesson to take away, that hopefully very few of you in this room will ever have to deal with that problem. But if you do, I think it's important to say you want it out. If somebody says we can cut it out, or we can do this, or we can do that, or we can give you an FDA-approved medicine called ipilimumab, I think it's okay to do it. But if you want to get a second opinion, or go to a center like Cleveland Clinic or UCSF or Ohio State or Sloan Kettering that sees a lot of these cases, I think that is almost as important as anything else, to sort of pause, to take a few weeks to say, can I plan this visit? Can I go get a second opinion? Because I think, again, just to acknowledge that there's a lot of anxiety and you want to get it done, right? So that being said, if you get to us, we have kind of a different population, because some of them self-select, meaning the ones who show up are the ones who have gotten that second opinion generally. So what we do when it's more than one spot, we ask ourselves, we do sometimes get our surgical colleagues or radiology colleagues to give us an opinion about the liver, because we're all saying liver, liver, liver. It's usually where you do run into the most problems. So a tiny spot in the lung may not cause you trouble over the next couple of years, but the liver might. The second question we ask is, just as we've all been saying, everyone's tumor is different. So how did it come up? How long ago did you have your therapy? If this is the first scan that you've had and you've got 2 or 3 spots, that's a little bit different than if it's, oh my gosh, 7 years ago I pretty much forgot about it, and I went to my regular doctor and I felt something and and there's 1 spot 7 years later. That's very different. So I think, that's part of individualizing that approach, and I think that's part of where going to people who have experience to think about these things, to not just put you in a box and say, well, I looked up online, you have melanoma that's spread, and this is what's approved, and I'm going to give that to you today.
Yeah, if you don't mind.
Yeah, go ahead.
Yeah, so let me add on to that. So I think that's a great point. I think it brings up a very good issue, that there's a few things. One, that judgment is very important, and you only acquire good judgment through a lot of experience. And so this is just a tumor. It's rare. Not a lot of places see it. And it's really something that requires a sense of what you're dealing with. It's something that you really can't find in textbooks. You can't find it online. You just have to treat it on a regular basis and use that to inform the decisions you make in the future. In general, though, and I think as we've kind of talked about, we do try local regional treatments first if it seems reasonable. Define reasonable, well, that's not easy to do. But we do try surgical treatments or radiotherapy-based treatments if reasonable first. But it's tailored. You have to take into consideration the patient. You have to take into consideration your judgment. I hope that makes sense.
And I think part of that, and feel free to chime in, but part of that is also what's available. So if you said that at Memorial Sloan Kettering, you'd get a lot of looks. They would sort of, what, always first you'd go for ablation, you'd burn it. Well, I think every doctor believes in what they do, right? We don't wake up every morning going, what I do is a sham, I'm gonna go, right? So you wake up every morning believing in what your science is telling you, what the people around you are trying to do. And so you have to also acknowledge that if you come to Memorial Sloan Kettering, we have a lot of trials that are pill therapies, and we believe in them. And we're not going to do something that's wrong for you. If you have one tiny spot that could easily be ablated, we would do it. But if you have 2 or 3, an area that doesn't have a trial may say, well, we have really good experience with ablating this tumor. If you come to us, we'll say we have really good experience with giving this pill therapy on a trial. And it's maddening, I think, because there's not a textbook answer and there's not a Google answer. I mean, there are 80 million Google answers, but, so I think, again, that's part of that, drinking from a fire hydrant kind of mentality initially. And so, I think both are right, neither of us are wrong.
So with opinions come biases, and with biases will have to be found out as the experience widens. So you say the pill works in your center, and if you try it in a center, it may not work, and they will tell you what the real science is. So of course, as things evolve, there's confusion, but I think getting 2 opinions might be good, but both opinions might be so different that you're forced to have a third opinion and then continue and may never reach an answer. So I don't know, somewhere along the line you have to feel comfortable with what you're hearing. But I think if you have any data, you should certainly ask for data and say, if you're advising this treatment for me, what experience do you have? What's the data? What does it tell you? It may not be perfect data, but it gives you something. So I'm going to highlight what Dr. Pugalenthi showed. He certainly showed that the tumors that were laser ablated, those patients did very well. So that benefit may not be from the treatment, it may be a reflection of the tumor itself, that these tumors are perhaps not that aggressive tumors, perhaps they are smaller tumors, perhaps they grow slowly, and therefore, whatever you do to them, these patients will do very well. So that's a selection. So it's not the effect of the treatment, but maybe reflecting the base of the tumor, of the nature of the tumor. Nevertheless, if that's the kind of tumor you have, you will benefit from this treatment. And when you show the numbers that 20% of these patients had more than 5-year survival, I think that's very strikingly different than we all know happens typically with melanoma. It's very rare to find more than 5-year survival after any treatment. So if this treatment is applicable to you for whatever reason, because the tumor is localized, then we know that 20% chance you'll live than 5 years. So there's nothing wrong with that data. It doesn't apply to every patient, but it may apply to you as an individual. So you really have to ask for those numbers. It's not a randomized study, it's not a multi-center study, but these are real numbers, these are not fake. So this is also something comforting. So if whoever tells you whatever treatment, you must ask for those numbers. And I think if you tease it out, you will still find it more useful than just say, I think you should have this and I think you should have that. I think thought is just a thought. You really need some kind of data, and I think that's very important. The other thing that came out from all the discussions and presentations is that if the tumor is localized, then you can do surgical ablation, and your data and other studies have indicated that surgical excision of liver metastasis, if it happens to be solitary, somehow is associated with very good outcome. And so if we can only do that if you actually look for it before the patient gets symptomatic. So that takes you to decide that we should be looking for it, because in small subset of patients, maybe 30% of cases, you're going to find a solitary tumor. And when you find a solitary tumor, then surgical resection would be a good option for you, and perhaps you'll fall into this group that will have a good outcome. So there's nothing wrong, in my view, being proactive about looking for that solitary tumor. If you don't look for it, you'll never find it. Then you'll have a liver full of tumor, and then you can say there's nothing can be done. So I think, although the data, if you look at a larger scale, may not prove this point, but little bits of information to me really favors that you should do systemic screening, and more than anything else, it also brings you peace of mind, some comfort. Like Dr. Budwell said, you know at least you're alive for, let's say, 90 more days, or something, like whatever the number is. So there's some comfort coming from all of this, and if you're not doing anything very expensive or very invasive, very harmful, then perhaps it's a reasonable thing to do. So I think that was my talk about scenarios, talking about adjuvant therapies. So there are a few other things that haven't been discussed so far, and I'm going to bring for your comments, because people may hear it on Google or other sources of information. Adjuvant therapy trials, perhaps using liver radiation, newly announced adjuvant therapy trials. So I want to warn all of you that soon we'll have more trials than patients in uveal melanoma. So select your trial very carefully, okay? Okay, this is just a warning. This is true, right? I mean, you have 6 adjuvant therapy trials, you're never going to get enough numbers. But anyhow, that's competition, and competition is important for innovation, but for evidence, you need collaboration. So somewhere along the line, something will come along, and then people will have to prove it in a bigger setting. So I'm going to ask you, maybe Michael, and all of you can go from this end. Mike, what do you think about radiating a liver with 25 gray in fractions in patients with high-risk melanoma that are likely to get metastasis, or as an adjuvant therapy? Yeah, from your facial expression, I can read a lot, but I have some words from you.
Covered up the microphone and I grimaced. So I think the caveat there would be that I don't know any of the kind of the preclinical data or any of the data that's out there. I would be concerned about that, just given the nature of the effect of radiation on melanoma in general. This is a tumor that does not tend to be overly radiotherapy sensitive. Now, if you say that to a radiation doctor, they'll throw in a lot of caveats. They'll say, well, technically this, and you can give it this way or that way, but generally speaking, it is not a tumor that's very radiosensitive, and the liver is, and the bowel is, and all the surrounding structures are. So I would be, I would need to be convinced.
Okay. Amudhan, what do you think about liver radiation with 25 gray? You are a liver surgeon.
So radiation and chemotherapy are good for rapidly dividing cells, and there have not been much literature out there for cancers of the liver other than melanoma for external radiation. There are experimental treatments, for example, like neuroendocrine tumors, where they put a catheter in the artery and they give radioembolization, which is like a brachytherapy. What they do is put a catheter, put some radioactive material that goes into the liver tissue, and that gives local radiation to the tumor. Those tumors which are supplied with very good blood supply can get this treatment. but I'm not really sure about the external radiotherapy per se for
the whole liver.
Melanoma.
Whole liver.
Whole liver, I'm not really, I mean, maybe it's down the line when other options are ruled out in a patient where like other options are not there. Down the line, you can, maybe it's like experimental.
Dr. Shoushtari, I know you believe in pills. What do you think?
No, it's not, well.
That's what Google says. Google says
so,
pills.
Yeah. So I think, you know, broadly speaking, there are a couple ways to look at it. One, from a doctor's standpoint, I think what you're sensing is some kind of skittishness because the burden of proof on any intervention is on the intervention to show that there is a benefit. How do we do that, of course? They don't just spring fully formed, you know, from the head of Zeus, right? They are, whatever, that was an Athena rep. Sorry, I'm Greek, sorry.
You're half Greek.
I'm half Greek, and I screwed it up. My mom's going to yell at me. All right, so they don't spring fully formed, right? They come from careful study. And someone mentioned earlier that when you're on a clinical trial, you have 10 of the smartest doctors at a center thinking about you every week, going, oh, those liver numbers are a little up or a little down. What should we do? And I think that's perfectly acceptable to go on a study that's trying to investigate something. It may not be right for you. That's a one-on-one decision you must make with your doctor. But because it's a study being offered in the United States of America, we have some kind of bedrock sort of control that a bunch of people looked at this and all decided, you know what, this is something that we can sleep easy at night knowing that we're exposing people to some risk, but we're looking at them closely and we'll learn from this. I think that's very different from a scenario where you know, in a country with 300+ million people and X amount of doctors, you can find a doctor who will find a reason to do something for you. And I think that's a little bit different when it's one person's opinion and exposing yourself to something that hasn't been proven in a study. And so that's the long answer of saying there's no way I would recommend it. But if there's a study that, you know, that was looking at you closely and we were going to learn about it and you liked that idea for yourself, then, you know, by all means, go ahead.
So I do want to add that these trials are typically approved by institutions after very careful review.
Sure.
And patients are monitored not just for the endpoint, but even along the line. And if the early or interim data analysis indicates toxicities that were not predicted or thought of, or inefficacy that's so obvious, then these trials are typically terminated even before they reach an end. So there is a continuous kind of interim analysis that happens all the time for efficacy, unexpected side effects, and all that. So it's not that you'll be treated without supervision, so to speak, but there are, of course, certain inherent risks. And it's the best, most educated guess versus mine. And sometimes you wonder, is aggressive cancer more harmful than aggressive doctor? I do not know. So that's also you have to think about. All right. So, and I think with that, I've satisfied myself in asking this educated panel. They have different backgrounds, and you can see when they speak, they have different preferences because we are all biased after all. So, having finished this part of the program, I'm going to open the discussion to questions from the audience, and I'm sure you have some. Yes. We have one person with 2 mics, so she's going to go around. Go ahead, don't feel hesitant. You don't have to tell your name.
No, actually, my wife had a question as well, so do you want me to answer your question for you? The question we had is, early on, there was hematomas in the liver that we were sort of cautioned that not to worry about, that almost anyone has hematomas in the liver.
You mean hemangioma, possibly?
Correct, correct.
Hemangioma, yes, they are very common. Mm-hmm.
Right, but then we had Mets, and our question is there any correlation between the hemangioma, yeah, whatever you just said, and yes, and Mets?
No. The hemangioma doesn't predispose to metastasis, but can confuse imaging. So if hemangioma, so that's why we like to do like a baseline imaging when you have the eye treatment first, so you know what the liver looks like, because it's not likely to have metastasis at baseline. And so if the baseline CAT scan did not show hemangioma, for example, and 2 years later on ultrasound you found hemangioma, I would be very suspicious because that's perhaps metastasis rather than hemangioma. But if you did not have a previous imaging, then it's sometimes hard to tell. And I know ultrasonography sometimes comes into play here, differentiating hemangioma from metastasis. So it's not the hemangioma can cause metastasis, but it may mask it or confuse or delay the diagnosis of metastasis. That's my view. I don't know about the panel. What do you think?
Yeah, to my knowledge, you know, even in the laboratory setting, and other people can chime in, there's really no relationship that we know of. But it's, you know, things are evolving all the time, but so far, no.
And the other question is, I'm going to show my limited amount of biology. The question is, when someone is at high risk, 12 millimeter or greater, actually in the eye, and then the way we sort of understand it is the cancer can travel from the eye through the blood into the liver to kind of create possibly of mets. The question is, has there been any clinical trial on actually swapping out the blood that's tainted with fresh blood that's not?
So after the tumor gets into the blood, the cells will seed in different parts. So you may remove the blood, but the cells have already escaped the blood, so to speak. Sure. So having total body transfusion, let's say, if that's what you're asking for, I don't think will help, because the cells have moved from blood into the tissues, and they're outside the circulation.
Sure.
What do you think, Dr. Amudhan? Do you agree with that?
I mean, I mean, it won't help.
It will not help.
It won't help. And the first question, that hemangioma, the expertise is very good now among radiologists. They can 99 to 100% say it's a hemangioma. We don't have to worry about it.
Yeah, and you do not want to biopsy hemangioma.
No one wants to biopsy.
Because it is it causes a lot of bleeding and serious complications, right? So you really have to be careful in imaging to say it's hemangioma. Okay. Yes.
Hi, I have a question about the clinical trials. There are a few of us that are class 2, and we've taken Sutent. We've done obviously the plaque radiation. We're a year out, a little bit more, and from what I've seen, the clinical trials are all very, very limited. It's to people that are newly diagnosed, haven't done any type of therapies at all except for plaque radiation. Can you talk a little bit about that? I mean, is there going to be anything available for us that actually have done a little bit of something and would still like to do a trial because we're class 2, and so if you could talk about
I understand. So just to rephrase, if you are outside the entry window for a trial, if it's 6 months have gone by and your cutoff is only 3 months, can you take something?
Yeah, and I can sense your frustration because you're doing what you can, and now you want to do more.
Because the trials are new, and when I was diagnosed a year ago, really the only thing that was offered to me was Sutent, and
Yeah, so a year ago I was looking at a blank screen, starting to write the trial. So I hear you. I think it's tough to. When we want to convince scientists, we're a conservative, stodgy bunch, right? And sort of by nature, we can't just say, "Oh, that looks good. Let's do it. Let's do it for everybody." And so, why do I say that? I say that because there's a sort of high bar to convince someone in a rare disease in the adjuvant setting that the pill that we're giving you that may cause side effects like lung inflammation or liver inflammation is worth it. And so how do you do that scientifically? You have to really take people for whom there's 2 ways to do it. One is to give half a sugar pill and half the actual thing. That makes the trial twice as large, and for a rare tumor it's sort of tough to do. You can do it, and people have done it, but that's one way to do it. The other way to do it is to say, okay, let's start with a very well-defined sort of uniform group of tumors. How can we do that? Well, Dr. D'Amato and other colleagues have sort of given us these risk stratification, sort of strategies, which is in and of itself a great thing. 10 years ago, or 15, you're making me do math. So before, the late 90s or mid 90s even, we had no idea, right? And so we'd give the pill to everybody, and a lot of people wouldn't need the pill to start with. So we have a little bit of a way to predict who might do poorly, just, by the numbers, right? But we have to say, okay, you have to have just gotten treatment. If you had Sutent, it may have affected something about the tumor. And when I go to try to convince Dr. D'Amato that my trial is working, he's going to say, you know, they got suits they got ipilimumab.
It clouds those results, right?
It clouds it. And unfortunately, you know, do I enjoy saying that to your face, that we can't put you on the study? Of course not. You know, I want, you know, all of us want to advance science. But unfortunately, that's the reason why we have to be very careful of knowing what's going on with somebody at the start in order to say, can we make heads or tails of what happens to people at the end?
So can you, for example, give the same drug outside that trial?
Right,
that
that's
you're
what I was
giving
going to ask.
in the
Could
trial?
I choose to take that drug because you do find it promising? I wouldn't be included in the statistics that you're looking for, and I understand that. So
But can she have it outside the trial? That's the question.
Again, and I don't know how you guys, or how you feel, Dr. McNamara, I would say unequivocally no. I would say no, there's no way you should do it. I think, and some people are a little different, and sunitinib is an example of, you know, a drug that's available. It's going to start up in a trial in Philly, but outside that study where we're not learning, you know, about it, and it's not 10 people looking after you, I wouldn't recommend it. As good of a doctor as I think I am, I wouldn't.
So maybe they think it's not safe for you to have it, and therefore you shouldn't have it, although you want to have it.
Well, but I guess just one last real quick little thing. If it's not safe, then doing a clinical trial is confusing to me, I guess.
No, but that's being
You know what I mean?
monitored. See, that's a very controlled situation. We are monitoring them. There is an onus of the doctors and institution to report all the outcomes and things of that nature. So it's in a highly regulated environment, where versus you could go to Mexico and take whatever oxygen if you like, and I don't know. So this is a whole different. The reason for it is because you are basically protecting the patients. In fact,
Yeah.
the whole structure is to protect the patients and not exploit their emotional, let's say, weakness at that time of need.
I mean, so what I would add to that is any and every therapy that we have has side effects. There's no doubt about that. And we know any therapy we give in the adjuvant setting is going to have side effects. And so what we're saying is that we know through studying this, let's say, that the benefits outweigh those side effects, that this is an effective therapy that improves your chances of being better in the future, and that you would take that then because you knew, even though it had side effects, it had benefit. When you look at drugs that aren't proven to be effective, all I can promise you is side effects. And some of those are serious. So, I mean, I agree with Alex. I think that if I have an agent that is promising, I mean, unfortunately, there's a lot of promise, but some things just don't pan out. Even if I have something that is potentially promising, I wouldn't offer it unless I had data that, you know, really, I wouldn't offer it outside of a trial unless I had data that showed that it worked. Because I just think, you know, if you give these drugs on a daily basis, you see that there are side effects, and every now and then, you know, people really get hurt. So it's not something we take lightly.
And to give concrete examples to what the difference is about a safety of a clinical trial versus being able to either purchase or get your insurance to approve a medicine off of a trial, is that, you know, the study's going to make you, let's say you have, you start the pill, you get an EKG, a tracing of the heart, you know, once every 4 weeks, it's sort of mandatory. You get your blood tests done every couple of weeks for the first 8 weeks, that's mandatory. We know exactly who's looking at those numbers because the federal government's going to come down on us if they find out that we're not looking at these numbers in a timely way. You have to come back every 4 weeks for the first 48 weeks, and then every 12 weeks after that. And even if you have a really good reason you can't come in, we'll give you some leeway, but after a couple of missed appointments, we'll say, okay, you're not getting the drug anymore. You know, and I think that's different than the real world. Sorry, I'm like ignoring this side of the room, but that's different than the real world, where a doctor's busy, a doctor's doing the best he or she can, but they're giving you a drug and say, well, how often should we check your liver tests? I guess maybe, I don't know, once every 2 or 3 weeks, I guess, and maybe things get busy and things get missed. So it sounds trivial, but the difference is actually striking in sort of how things are run on a study versus off.
So in balance, one can say that our own experience here, that these trials are conducted in an environment to protect patients from exploitation. that is the fundamental of all the IRBs and all the HIPAA regulations that we follow,
And
is
to
protect
aggravate
patients'
doctors,
rights.
too.
So all the trials are therefore beneficial because they're protecting whoever is in those trials. There's a gentleman here with a very important question, I think.
Are there cases where you're unable to do a liver biopsy?
Doctor?
Yes.
Yeah?
Yeah, so I mean, there are times it's difficult to do. That's actually perhaps one of the problems with surveying the liver, is you take someone who feels perfectly well and you image them, and sometimes you see something in a difficult spot. And, you know, it's, I mean, I'm not a radiologist, I don't do the biopsies, but I've heard them. It's right next to a vessel, it's too deep, it's here, it's there. So then what do? Well, you know, you've got to use some judgment. I am very reluctant to start people on therapies unless the imaging is convincing and I have a diagnosis. So ultimately, you can wait a little while, repeat the scan, see if it's biopsyable at a later date. If you're in a pinch, you need to make a decision. I'm sure there's circumstances that are like that. Then there's other imaging tests that you can use which may make you feel more confident about what you're dealing with. But I don't know how many times I've been in conference and people have said, what else can it be? And 1 out of 10 times it's something else that you wouldn't predict. And, you know, so really, again, it sounds kind of stodgy. I like that word, now I'm gonna use it for the rest of the day. But you really want to know as best you can, and a biopsy, as simple as it sounds, is really important to get, and so we try, we really do.
A question here, yes, go ahead, sorry.
Yes, I'm at UCSF taking PD1, and I have taken 5, had a PET scan, and there's some minor growth after 5 infusions, and the doctor is recommending I see a because I have multiple spots in my liver, the doctor is recommending that I see a radiologist concerning a TACE. I don't know.
Transarterial chemoembolization, right?
Yeah, and the rationale behind that is that sometimes, not always, but sometimes those antibodies can get kicked up and help the drug be more effective specifically with the liver. So what's your opinion on that? Do you know anything about that? Research?
Yeah. So basically, any organ to grow, it needs a blood supply. Basically, the tumor also needs a blood supply to grow. So what they do in TACE is, as I said earlier, they put a catheter into the artery and where the blood supply to the tumor is, and then give chemo drugs, like chemotherapy drugs, targeted just to the liver and to the tumor. And then once it's acting there and they embolize it, meaning that they'll stop the blood flow to the tumor and also the surrounding liver tissue so they die. So it's a dual therapy. One, you give chemotherapy directed just to the tumor in the liver, because we cannot operate on them because it's extensively spread in the liver. And also additionally, you have a benefit of stopping the blood flow to the tumor. And I don't have much data on the TACE.
Third thing is the component of immune enhancement of.
Yeah, so welcome to Cleveland then. I guess the weather here is probably much better than it is at, so, you know, I think that these are new drugs, and I think there's a lot of unanswered questions in terms of PD-1 and CTLA-4 drugs. And we know they work many times. They don't work for everyone. And so people have said, well, are there ways we can enhance the effectiveness of these drugs through either the timing of administration with other drugs, through radiation? Are there ways we can modulate it so that these drugs work better, so they work in more people? And, you know, I don't know the answer in terms of TACE. You know, I think, I don't want to tell you it's a bad idea or a good idea. I think it seems very reasonable. I can't tell you that there's some huge paper where we know TACE improves the outcomes, but I think it's reasonable.
Also, they're doing a PDL1 MEC trial, and so they're hoping that I can do this piece and then get into, be approved for that trial. But it's all kind of a...
Yeah, no, there's a lot of uncertainty, as he said, about how to do this. I can tell you that this is, they're smart people there. This is stuff that we've done before, and the thought is, okay, as he showed sort of the cells and the, showing the bad protein and trying to...
That's very helpful.
Right. Trying to get, wave the rag in front of the bloodhound, and say, okay, go get it, immune system, and so the idea is if you do a treatment that has some side effects but has some benefits, i.e. shrinking a liver tumor, at the same time, is it going to release some proteins and is it going to wake up your immune system? That's the thought, and I think it's reasonable to do. I know the study you're referring to that's after, and again, that's a way to get another immune-targeted drug that's not available, and trying to combine it with something that we know has maybe some benefit in uveal melanoma, as I'll talk about. So again, we don't know you, we've never met, we don't know the details of your case, but it sounds very reasonable to try, from what you're saying.
I think we have a last question. Go ahead. Maybe two last questions. Okay.
My question is in regards to ablation. I'd like to get a little bit more clarification on that.
I can't hear you, sorry.
Okay. Clarification on ablation. Who would be the ideal candidate for that type of procedure? And just to make it a little bit more clear on what I'm asking, in my case, I've had several procedures done. The last was a SIR spheres. My particular tumor is considered aggressive, but right up against the IVC. Would someone myself or someone else in a similar situation, would we be a good candidate for ablation?
But if it's close to a bigger blood vessel, the ablation will not be very effective because we use heat-based therapies, and because of the blood flow, the heat is taken away when it is closer to a blood vessel. We call it like a heat sink therapy, like heat sink effect, and we don't ablate, and it's not also safe to put a needle next to a big blood vessel like an IVZ and burn it and make a hole in the vessel and make it bleed. So it's not safe, and it's also not perfect because the heat is taken away by the blood flow in the IVZ, because that's the biggest blood vessel which takes blood from the lower half of the body into the heart. So it will not be very effective, and also it might be in a very difficult position because the IVZ is a very difficult spot to access because the needle has to go penetrate and to reach them. There may be technical difficulties in reaching the spot, and also if it's close to a big blood vessel, they're not candidates for ablation.
So you have to look at the image of the liver to figure out whether it's suitable or not.
Yes. We have to look at where the lesion is, how far it is from the blood vessel, how deep it is. So that may be the answer.
Thank you very much. We have one, I think, last question. Grant, is that?
Yeah. Okay. So broadly speaking, this is about clinical trials, and I wanted to put Dr. McNamara and Dr. Shoushtari on the spot here, so I'm going to hold you to a question or an answer. But I'll give you the parameters, all right? So somebody's got mets to the liver, multiple lesions, both lobes, surgery's not an option anymore, gone through chemo immobilization, and that's now progressing. So your last line of hope really is a clinical trial. And when you look up all the clinical trials, trial A, trial B, trial C, if you choose trial A, you're immediately out of trial B, C, D, E, F, right? So I have to choose one. Which one do you choose at this point? Dr. McNamara first.
No, that's actually a great question. I think this is something that comes up in clinic frequently, and certainly when people, I'll see people and I'll say, look, here's what we have. And some people are able to travel, and they'll go to Sloan, they'll go to other centers, and they'll be offered a few trials, and they'll go, and it's almost feast or famine, and now they've got all these options, and they know there's only so much you can eat. You know, you can only do one. And people struggle with this because they feel like they need to make the right choice. And they look to their doctors and they say, what's the right choice? And by definition, all these therapies are on trial, and the doctors go, I don't know which one is better. If I knew, they wouldn't be on trial. They wouldn't be an investigational therapy. You really have to do this. You have to take a doctor that you trust, and you say, help me make this choice. What in your personal judgment, you know, is my best option? And it's not an easy choice, and there's no kind of right way to come up with the answer. I hope it doesn't look like I'm dodging the question, because it feels like I am, but that's a very hard part of having trial options, is picking the right trial and having this feeling like if you don't pick the right one, you've made a mistake, and you know the costs are high. I don't know if Alex, you guys have got a bunch of trials at Sloan,
yeah.
So it's always an issue.
No, I mean, it comes up all the time, and this is what I've learned to think about. As I said, I have the luxury of, I'm young, I have fewer gray hairs, but I've seen a lot of uveal patients go through this. And so one way to look at it, well, I certainly agree with everything you've said. There's no data that tell us, I'm convinced this is better, I'm convinced this is better. We don't have it. I agree with you, you have to find someone who you can trust. And also someone who knows the landscape of where it's feasible for you to think about a trial. The one thing I think that's hard is, especially let's say people come to New York from wherever and they can't come all the time. They come once every 3-4 months or whatever. I think I'm doing them a disservice if I talk up all these amazing trials that I have here in this ivory tower of Manhattan, when I know that you can't take off work, you've got kids, you've got a job, you've got all this other stuff. So you have to find someone you trust who's going to discuss options for you, and if you say, I can't do that in life, I just can't do it, then there's no use beating up, yourself up over that. So when they come to us and say, I can come to Sloan, the second approach I take is, or that Dr. Carvajal, my mentor, is teaching me to take, is how many bullets do you have in your chamber depending on what route you take? And what I mean by that is, you mentioned if you go on trial A, then B is out or C is out. So that's where, I can give you an example off the top of my head that if somebody in the community gets ipilimumab, which is FDA approved for melanoma, the government doesn't tell us, oh, it's uveal, you can't use it. You can use it. But if you get ipilimumab, you're ineligible for the MEC-AKT trial that I'll talk about. I'm sorry, you're ineligible for the what's called, there's a trial that has a fancy, stupid name. It's called Summit, and that's selumetinib with dacarbazine, and you're ineligible. Sorry, but you would theoretically be eligible for another trial. And so we say, okay, if you get IPI, that closes that door. If you get IPI, though, it opens the door if you progress to get pembrolizumab, the PD-1 drug. What do we know about that in uveal melanoma? This, okay. People are tweeting that there are anecdotal responses at ASCO. That's kind of the state where we're at. We're learning from Twitter, what we're doing. So that tells you, right, this is what we don't know. Yeah. And so you have to sit down with us or other smart people and say, okay, if I go on IPI, I'm out of this. So you asked a very pointed question. What's the first line? What's our recommended first line? We have the benefit of 2 upfront trials, the MEK inhibitor with the chemo, that's trying to prove whether or not MEK inhibitors have benefit, or a MEK inhibitor with the AKT inhibitor. And so a lot of that is based on the patient's side effects and certain things, like if you're diabetic, one is way worse for you than the other. If all things are equal, it honestly may come down to schedule. It may come down to talking about the side effects. One is a higher risk of X or Y, and that's how we come to a decision. So it's not like a better or worse. It's sort of, it's a process.
Well, I think we should close. 8 minutes late for lunch, but before we go, I want to say that hopefully next 5 years when we meet again someplace, we will not be so dodgy, we'll be more clean. Thank you very much.